Good evening, everyone. Welcome to, I am Elizabeth Roberts, actually, before I welcome you. I am the Director of the Academic Health Collaborative here at URI, and welcome to From the Front Lines, the first panel in a three-part series that is being sponsored by the Academic Health Collaborative and the Interprofessional Education and Practice Initiative. We are focusing on the way that our health professionals here at URI have been playing a part in the COVID response. Tonight, you will hear from 5 graduates of our programs in the 3 colleges of the Academic Health Collaborative, colleges of Pharmacy, Nursing, and Health Sciences. Each of them will talk about their experiences as individuals, and also we are asking them to talk about the impact of working either formally or informally in a collaborative health professional team. Something that would seem very important in such a complex and unpredictable illness as COVID has shown itself to be. For our audience, I want you to know that we will have a question and answer period at the end. And if you could please type in your questions into the Q&A, that we will then get to as many of them as we have time for. And as we begin, I'd like to introduce our 5 panelists. Just give me a moment here. So our first is Dr. Eugenio Fernandez. Dr. Fernandez is the founder of Athenas, a community pharmacy offering free public health guidance and health education to community members, located within the affordable housing complex at Wigan Village in Providence, Rhode Island. He earned multiple degrees at URI, simultaneously a bachelor's of psychology and biology, an MBA, and a doctor of pharmacy, all in 2013. Welcome, Dr. Fernandez.
Thank you for having me, Elizabeth. Pleasure.
Great to have you. Now I would like to introduce Dr. Trudy Ann Gale. Dr. Gale earned her doctorate in clinical psychology from URI in 2011. She is a licensed clinical psychologist, currently based in New York City, and a senior staff psychologist at a nursing facility. She is also the CEO and co-founder and director of clinical services of Life Matters Psychological Services, LLC, where a variety of licensed clinicians provide therapy and other services to a largely minority population of individuals, couples, and families. Welcome, Dr. Gale.
Thank you for having me. Appreciate it.
Next, I'd like to introduce Leah Hurley. Leah received her bachelor's degree in 2016 and her master's degree in food and nutrition science in 2018, both from URI. She is a registered dietitian who has worked in many clinical settings in Massachusetts and Rhode Island through the COVID pandemic. She has recently taken a position at Beth Israel Deaconess Medical Center in Boston. Welcome, Leah.
Thank you, Elizabeth. Pleasure to be here.
Now I'd like to introduce James Lemieux. James is a board-certified critical care nurse who has been caring for critically ill patients and their families in an ICU setting, with and without COVID-19, his patients are with and without, during the current pandemic. He earned his Bachelor of Science in Nursing from URI in 2018 and is a candidate for certification as an adult gerontology acute care nurse practitioner and for his doctorate also of nursing practice. Welcome, James.
Thank you, Elizabeth. Glad to be here.
And last of all, I would like to welcome Shannon O'Rourke. Shannon is our newest alumna on the panel, graduating last May with her bachelor's in health studies. During her time at URI, she discovered a passion for public health. Since graduation, Shannon has been working at the Rhode Island Department of Health, supporting the COVID-19 response. And welcome, Shannon.
Thanks, Elizabeth. Happy to be here.
So I'm going to ask my first question, and actually, Shannon, perhaps I will start with you. This has been certainly an exciting moment for you as what was likely an intern and then being hired full-time to work on COVID response, right at a time when the university was also changing to online. You didn't even get your graduation. I'm really interested to hear you talk about your experience. We know you're working at the Department of Health. What have you been doing? And what are the unexpected experiences you have had as you've taken on this role during COVID-19?
So yeah, it's been a crazy ride, definitely. For anyone who doesn't know, and Elizabeth had mentioned, I was an intern at the Department of Health. I started in January, which seems like years ago. But I started there with the oral health program, working with a lot of oral health programs, but also nutrition education as it related to oral health. And then once the pandemic hit in March, basically nothing that we were working on mattered, and it was all COVID. So I jumped in and helped out with whatever I could. When the pandemic first started, there was no formal reporting process at the Department of Health. We didn't even have a database system set up. Everything was on paper, and it was a lot of managing and tracking of cases. Since then, we've become very sophisticated. I'd say we have one of the best tracking mechanisms within the U.S. Honestly, we've been able to grow a lot, and they've hired a lot of staff. When I started in May, I was a general community case investigator. And basically what that means is anyone who tests positive for COVID, they would be contacted by the Department of Health to do an interview. And that interview would collect things like demographic information, information about their workplace, symptom onset, most importantly, so we can track their infectious period starting, and then getting their direct contacts, either social contacts, household contacts, and workplace contacts, and notify them of their quarantine periods. So that's kind of how I started. And since then, I've been able to move up in a few different ways. We have a lot of teams at the Department of Health within the COVID unit. So I have been working on specifically the employer team probably since June. And that team is all about outreaching to businesses throughout the state who have employees that test positive and have worked in person during their either infectious periods or symptomatic periods, and we're counseling them on disinfection, deep cleaning, being able to contact trace internally within their departments, and prevention measures, as well as making sure that employees are being actively screened while going to work. So that's where I'm at now. I would say some of the most unique or unexpected experiences that I've had is definitely the first thing off the bat is working during a global pandemic. When I think about it, it's kind of surreal, like all of the work that has led up to where we are now. We've made a lot of progress since March, and there's still a lot of ways to go. But I would say most importantly is being able to have a positive impact in such an unexpected time, and when people are really struggling to either recover from COVID or just to get education and protect their families and their employees during this time.
Thank you so much. Dr. Gale, so you are not in Rhode Island, where much of our audience is. Would love to have you talk about your experience in something we often don't think of as a major impact of the pandemic, and that is mental health. And if you could share some of your experiences.
So currently I work in a subacute nursing facility and long-term care facility, as well as I have my private practice. And I've found that my clinical experience has been relevant to both. I didn't think that it would be so relevant in the nursing home, but as the days went on and I would go into work, I would realize how much I was needed as the patients went into isolation, because their families stopped visiting at the end of February, maybe early March. So, a population that's used to having regular visits, clean laundry, maybe food being brought to them, and just general support, they were basically that stopped. And as I would go in and news was coming in about the pandemic and what it all entailed, as much information as we had at the time, it became more for me that I needed to step up and sort of not replace the family, but offer that support that the family would provide for them, visiting more often. So I'm usually seeing my patients in the nursing home once a week, and I was upping my visits to twice a week because the isolation started to set in, withdrawal because they weren't able to, populate in common areas. They were isolated to their rooms, and they still have been isolated to their rooms pretty much for the last 6 months, just so that they can keep the spread under control. So with isolation and the uncertainty of what's going on, they're watching the news, you can imagine the anxiety sets in. And then the depression started to set in within maybe month 2, month 3 of not seeing any family and just feeling like I don't know what's happening. And interestingly enough, they were seeing their peers or hearing of their peers in other clusters or in other rooms that were passing away from the virus, or hearing that their peer went out to the nursing home but never to the hospital, but never seeing them return. And so working through that process with them of what's happening, what's going on, is it me next, I have underlying conditions, and just helping them to cope the best that they could with all the uncertainty and the chaos. I think I helped the staff as well because we were all shocked. I walked into work one day, it was like no mask, and the next day I walked in and it's like, Dr. Gale, you need to put your mask on, and this is mandatory now. So just trying to alleviate some of the anxiety of the staff members as well, as they would come to me and say, hey, this is happening, and just communicating amongst each other so that we could allay the fears of the staff and being all on the same page. I would say from the private.
Could I ask you a quick question as you're telling that story?
Sure.
Were you a nursing home where there was a significant number of people who passed away, or did that not become a part of what you were coping with?
Yeah. So I'm a little bit leery about talking about that. And the reason for that is that New York State, if you don't know, the nursing homes really were hit very hard with the pandemic. And the facility that I'm currently in is under some litigation, and there's some issues going on there with it. So I'm just gonna.
Yeah, I certainly don't want to put you in a difficult position. And if you don't know, Rhode Island was the second highest state in the country for the percentage of our deaths that occurred in nursing homes. So
Yeah, I think New York State was one.
So I apologize for that. I didn't realize it was a difficult situation legally.
Yeah, it's still ongoing, and many staff are dealing with, I guess, backlash from being outspoken about some of the issues that we were dealing with initially as we faced a pandemic, and no one had enough information to deal. We didn't have what we have now back then in March when everything hit. So we're still struggling, but I don't know if we have enough time, but the private practice realm, my private practice literally shut down. We have a space that occupies 8 clinicians, and we had to turn everything over to remote, doing sessions by Zoom and other platforms, just to kind of keep our patients safe and make sure that they were okay. In fact, in the process of doing that, we found out many of them were positive because we could see them and that they were struggling. And we say, hey, you need to get to the hospital. And many of them actually listened to our advice and got into a hospital. So
thank you very much.
So we're in.
Yeah, and you will have more opportunity to talk about some of these as we go along, some of these issues. So James, if you would like to share your experience as an ICU nurse, I think that would be, as so many of us think of this as a disease where many people spend significant time in the ICU.
Yes, and that's very true. But what a lot of people don't understand is a lot of people that are hospitalized for COVID never make it to the ICU. Percentage is actually small. There are people that aren't as affected as seriously as some people that come to me. But I will have to say, in an acute care setting, we've been treating COVID on a 3-tier level, really. We treat the patient, we treat the staff, we also treat the family. And building on what Dr. Gale has mentioned, psych is a very big component. And in the setting that I work in, the psych is related to the families, because a lot of the people that I treat with COVID, they're either in medically induced comas or they're unconscious. And a lot of these people, unfortunately, have perished, and their family members can't come in to see them. They can't come in to say goodbye. They really don't know exactly what's happening other than what they're being told. And they don't get an accurate assessment of what that actually is. So it's not easy telling a family member over the phone that their family member has passed or is expected to pass in a short period of time. And that's where the psych level comes in. And it's something that was, from my perspective anyways, wasn't expected. Because generally, in my line of work where I am in the hospital, people, unfortunately, they leave us quite frequently. But families are always welcome to come in and, sit and be present and, make the passing of their loved one easier on themselves and the patient themselves. Now they can't do that. So it's hard to relay that information in a way where you can be sensitive enough to make all their needs met. That being said, once that is accomplished, we don't know where they go or what happens to these people shortly after we've spoken with them. And that's difficult because the unknown is always difficult. So there is to what Dr. Gale has mentioned, that the psych component is very real, even though it's in a different setting. And I'm sure she can speak to that too, dealing with families of the patients that she works with. It's really this whole pandemic has really turned healthcare upside down. Things that we do one day are totally different the next day. And you don't know what to expect when you come in. Things have somewhat normalized, but I can tell you, March, April, May, you would leave work one day and go in the next day and, all hell would break loose, because what happened the day before, we can't do that anymore. That's unacceptable. From PPE to protection for staff, protection to patients, treatment. I can tell you that treatment for COVID, as I'm sure Dr. Fernandez can tell you, has changed from day one to today, and is still changing. Use of steroids and remdesivir and you name it. Things that we used 6 months ago, we no longer use because they're deemed unhelpful or harmful to the patient. And it's one of those things where the uncertainty is it's troubling. Because as a practitioner, you really want to do what's best for your patient. And when you don't really know what is best for your patient, it's difficult to go back every day and continue to do what you're doing when you don't know if the treatment's going to be the same in the near future. So,
well, you mentioned Dr. Fernandez, and if we will move on and have him share some of his experiences, and James, we will be back with further questions. But Dr. Fernandez, you have been in the neighborhood, in one of the highest neighborhoods with one of the highest infection rates in our state. I'm very interested in your experience over the past 6 months.
Yeah, sure. So that is true. So I'm the founder of Steenis. We're in Cranston Street. It's just a low income area. It's actually the neighborhood where I grew up in. I grew up on Hanover Street. So primarily, as you've probably heard in the news, there's certain demographics that are disproportionately affected. And they tend to kind of correlate with your income status and other social determinants of health. So it is true. There are a lot of people around here are affected. A lot of my patients were infected with the virus, and our goal was, at least initially, was to convince people to stay at home that were positive. It might sound a little bit counterintuitive, but the issue with just sending, as what James pointed out too, not everybody that goes to the hospital actually needs an ICU bed that has COVID. The medical condition, the prognosis is poor. It's a dangerous disease because you don't know how it's going to affect one person to the next individually. But if you are positive with COVID, you could overwhelm the healthcare system. If everyone goes to the emergency room and then fills up beds, they come to James ICU, then James says, I don't have any space, right? COVID is such a difficult virus because it's novel to the human race. So we don't know how people respond to it. We don't know, we were trying to understand and learn as it was spreading. So certain things like happy hypoxemia, like some people would have low oxygen count and still be functioning normally, where normally in medicine, we would put up red flags and say, send them to James. So there was a lot of, what we were trying to do is just keep people, okay, if you're sick, take Tylenol, rest, try not to rest on your lungs, on your back, try to rest on your belly, just try to educate the community about staying at home, and reserving the hospital for those that got really, really bad with COVID, that got worse. And those are the folks that we were sent to the ICU. So what was a little bit unpredictable at first was, and it goes to Dr. Gale's point, was the anxiety. So I didn't anticipate that being an issue early on, and it was kind of a compound issue for us. It's kind of compound in the community for us because people could not get out, so they were more anxious. So in dealing with that anxiety, they would call or they would want to speak with somebody. We are pretty accessible. So if you call, someone picks up, I pick up the phone and I'm speaking with you. Whereas other places, like you get this long message, like, okay, wash your hands if you have COVID, do these, take these kind of steps for social distancing. So people just wanted, when they were anxious, they just wanted to speak with somebody. So what I didn't anticipate was becoming the neighborhood psychologist, just getting the call from everyone left and right, and just kind of, they just wanted someone to hear them out. So one of my undergrad degrees at URI is psychology. So not a psychologist, but I just kind of took the approach of, okay, let's try to calm this individual down. Let's just let them speak, because people were just alone. And in the loneliness, it just resulted in anxiety. And then that anxiety just kept coming and just kept hitting in waves. So just to sum up, our experiences were, yes, we were in a hard hit area. Yes, a lot of people had COVID. Yes, I've interacted with patients with COVID. And our goal was to keep them from getting really, really sick and going to the hospital and overwhelming the system and creating problems for people like James. And at the same time, like Dr. Gale, trying to just be there for the community when everything else was closed. And just trying to just be that ear people were listening to, what we're looking for, so that so they can kind of voice their concerns. So that's kind of like been our experiences so far.
Thank you so much. So Leah, you had some similar experiences working in the ICU, but also working on the traditional medical floors in an illness that had some things, unique impacts on people's ability to eat as one would normally eat. So talk about how dietitians have been really important and what your role has been.
Thank you. So prior to the COVID pandemic, I was mainly on the surgical floors. That was my role. However, as we all know, all the surgeries were shut down. We were trying to preserve PPE, and a lot of the surgical floors actually became the general medical floors for the COVID patients. So that was my role to kind of take on everything. And like James was saying, it's just so new. Things were changing every day. We could address one thing one day, but then the next day, it was something different. And so, I think everybody is in this too. We were growing, we were evolving, and we were, consistently and persistently learning more as much as we could. We always wanted to be, we always, as healthcare workers, and I guess everybody can agree with me, we always want to be the best advocate for our patients, and we want to provide the best care for them. As Elizabeth was saying, COVID was a new illness. We don't know much about it. We don't know the manifestations of it. We did come to learn a lot though. And, we came to learn that people, even if they didn't need an ICU, they were very sick, and they were, when you're not sick, just, the normal person, you just don't feel well. You're high temperature, maybe you have some abdominal distress. You just don't feel like eating. Food is just something that, it just doesn't feel good. It just doesn't feel right, but it's so important, for your recovery and as you, progress and hopefully, get better. So that was, something that we really had to buckle down and try to improve in our patients, especially on the more general COVID floors. We actually, at my hospital, we implemented new menus, more focused around like comfort foods for them. We offered soups that we hadn't previously done. We did sandwiches. So we were really trying to make them as comfortable as possible. And like Dr. Gale and Dr. Fernandez were saying, they didn't have their family around. It was a big, a lot of emotional distress, tied into just not feeling well. So a lot of the times, we would reach out to family members and say, what is their favorite food? What could we get them to have? We were making milkshakes. We were doing all of this stuff just to try to encourage, as best nutrition as we could with these patients. It was tough, but, we really wanted to provide the best care for our patients. Switching gears kind of in the ICU, the more sick patients, that was also, very, it was evolving. We didn't know how to really care for them. We used a lot of the recommendations by, the governing bodies, the critical care medicine guidelines, the Academy of Enteral and Parenteral Nutrition, but it was very new, and we were learning a lot, and we were wondering, how can we feed these people if they need to be in the prone position and laying on their bellies? Can we do it? We were talking with the nurses, talking with the doctors, bringing in the whole healthcare team to try to provide the best nutrition care in hopes that we preserve their lean body mass and help them get better and on the road to recovery. So.
Thank you very much. Dr. Fernandez, I'm going to come back to you because one of the, as we discussed at the beginning, one of the things that seems so important is for interprofessional teams to work well together in meeting the complex needs of patients. And you had talked about how, and I think many people here have talked about how they kind of adopted some of the roles of other professions in doing their work. But can you talk about how either formally or informally, there were collaborations that grew for teams to meet the needs of the patients that you were seeing? And especially, how did some of those teams enable you learning more about what they did and them learning more about what a pharmacist with your approach to pharmacy in the community would be doing?
Sure. I mean, in terms of interdisciplinary teams, I wish I had Dr. Gale with me early on so she can kind of help with some of the anxiety that was going on. But with who we actually interacted with, we reached out to the COVID planning team for the state early on. That's an interdisciplinary team in itself. They were in charge of just managing COVID-19 within the state early on. And one thing I mean, immediately, just my public health background, I knew that, okay, testing is coming at some point, but we're not there yet. But what do we need to do is just educate people, right? And just tell people, okay, take this seriously because there's a lot of complex information out there. So, but we should take it seriously. So that COVID-19 planning team, they were able to give me CDC guidelines that they developed at the Department of Health. And what I tasked myself to do was, I said, okay, look, the community, we needed it both English and Spanish, and it has to be both back and front. They were able to deliver on that, right? Because people here, some people speak only English, some people speak only Spanish, some people speak a little bit in between, but having the both in both languages would make each piece of article important and relevant for us. They did that. They were able to deliver that. They got us a bunch of flyers, and then I went to all the places I knew where people usually fall through the cracks high risk populations, and we just delivered that information and we just let it out there. That was important because one drive I used to have in the morning on my way to the Steenis was I would see this is a basketball court and people would play basketball in. That I remember when I was growing up, and when COVID hit and we were shutting down, people were still playing basketball. Drive by people Tuesday, people playing basketball. Wednesday, people playing basketball. We did the educational thing, and after a while, I just drove by one day. The basketball hoops were gone. They were just taken off. So there was some action taking there. There was a lot of effort and interventions put in for folks to practice social distancing. But one important component was the educational. So taking someone's basketball hoop without knowing why is going to be accepted differently than getting information out there and then taking away the basketball hoop. So people were questioning more, and they were more vigilant, and they were reading more. So working with that COVID-19 planning team and getting the right information from the CDC and the Department of Health in the hands of people that are most vulnerable was huge early on. The second part of your question, I believe, dealt with.
Actually, the second part was really about, did other people that you work with, other health professionals, learn more about what you do as a pharmacist in the community?
Absolutely. Yeah. So our motto of Steenis, we're built for health education. So we were basically designed to be a place outside of your doctor's office to get information about your health, because we realized doctor's office visits were too short. Doctors would say that. So often people would have a lot of questions about their health and they didn't know where to turn to outside of their doctor's office. That's reliable, right? There's the internet, there's WebMD, but something that's reliable. So we want to create something in the community that's a community source for reliable health information outside of your doctor's office. We have the pharmacy, and I know you bring up the pharmacy part because the pharmacy is important because that service has expenses associated with it. And the pharmacy is just there to help finance those expenses. So we just build third-party insurances and we use that margin to help cover the free health education we do on the front end. So yes, during the COVID pandemic, we are essentially a public health focused pharmacy. And that information became more clear. It became more evident when the need for health education was essential in the community. We tried our best with our limitations to get it out there for folks. And it wasn't just like the pharmacy part. The pharmacy part was just the finance, but our public health, what we were doing on the Steenis, what we're about, other professionals started to learn about that. Other professionals started to inquire. Other professionals started to refer patients just for health information about their health. Or if someone tested positive, people from the neighborhood would call and ask, okay, where can I get food? Where can I turn to? And we were just there to guide people during tough times with public health information, the right information, the reliable information. So absolutely, people learn what we're about through that process. Other healthcare professionals, indeed.
Thank you so much. So James, in the work in the ICU, I know that teams are an integral part of how you do your job. I'm interested whether COVID changed that, made it more important, and whether you have anything to share about how those teams led to better care.
Well, it's always been important. The importance of interdisciplinary communication has never been unimportant. I think it's become more focalized. People who are afflicted with COVID who end up in the ICU are seriously sick. And a lot of the public probably view this as a respiratory condition, which it is. But when these people get to the level of illness, when they reach the ICU, it becomes a multi-system organ problem. So, you need cardiology, you need hematology. We have people that have clotting issues, the ARDS, certain vent settings, respiratory is involved, clearly. From the head to the toe, these patients are being cared for from various specialties. Like Leah was mentioning earlier, as far as like nutrition goes, we have a COVID patient who's proned in a rotoprone bed. Typically, sometimes tube feeding doesn't work well if they have a peg tube because they're lying on their belly for 16 hours out of the day. So they need parenteral nutrition, which needs to be given through a central device. And that's all, dietary is involved with that. And, there's certain levels of potassium and calcium that goes into these things, and insulin that, has to be figured out. And it's detailed to that patient's specific lab markers. So everybody's involved, and it's it's very intricate because, you know, you have one patient who's suffering from COVID in one room, and in the next room you have another patient who's suffering from COVID, but their plan of care is totally different. So it's very complex, and it's you know, back to my original point from the first question, you don't know what to expect. You know, these people, they change daily. We have somebody who's got a coagulation issue. They start them on heparin because a lot of these people do have coagulation issues or suffering from COVID. Next thing you know, they go into a condition called heparin-induced thrombocytopenia. Then, you know, they can't be anticoagulated anymore, and then the whole system changes, and it really is, it's a mess, quite frankly. And the fact that you have everybody working together, it does make things happen in a smoother way. Because, you know, if you've got 7 brains, it's working on one problem. It's a lot easier than having 2 brains working on one problem. And you get to the point where, you know, everybody respects everybody's decision, and people are trained and certified in certain areas of critical care. And it's amazing how they all come together to arrive at one conclusion, and the plan of care for that patient is agreed upon. And it literally takes 5 or 10 minutes. And 24 hours later, when we convene again, totally changes. But the same team is there 24 hours later. So there's definitely a continuity of care between disciplines. And that's very important.
Thank you very much. So Shannon, you're in the health department. You're not, you're on the front lines in a very different way. How have people come to know what someone who's a community health worker in many respects, but is inside government working with the community? How have you engaged with other members of the team, and have they come to understand your role?
Yeah, so my role is definitely a lot different than the frontline clinical acute care setting. But what I find very interesting is working with a lot of our public health nurses who do have backgrounds in the clinical setting in their past careers working in hospital and inpatient. What we have seen across the board really is having teams and being able to communicate effectively has been the number one problem solver to COVID. Obviously, we still have a ways to go, but being able to kind of group COVID into different sections to really pinpoint the guidance that certain individuals need. So with the reopening of colleges and universities, with elementary K through 12 schooling, we've decided to create specialized teams. So we've got college university team who deals with college students, professors, anyone really on campus that is looking for specialized guidance. We have the K through 12 system, and we've also developed a specialized testing process for those students and staff as well. We have long-term care facility teams that are working with our nursing homes, with our assisted living. We have home health care. We have childcare teams. And then we also have a group home team and the employer team. What I would say to be the most rewarding is working within mostly non-clinical general businesses such as like manufacturing, personal service businesses. Really, I would say a big component of our work is working with the businesses who have frontline workers that aren't necessarily considered critical infrastructure, but they have continued to work through the pandemic, and they don't have the privilege of working remotely. If they're in like a manufacturing setting, if they're within food manufacturing or food service or things like that, and they're kind of those frontline workers that often get overlooked, and being able to work with their management and their leadership to keep those workers protected. I think a lot of employers have really got an understanding of how important public health is, because they hate to see their staff out of work and not being able to to really keep their production going and their businesses flowing as they would like. So I've come to find that a lot of businesses have really placed a big importance on public health and providing those resources to their employees.
Thank you. Dr. Gale, you talked when you shared your experience earlier about how you really have two places that you work. One is the nursing home. The other is your clinical practice, which moved to a remote, as we all are having with our medical providers on Zoom. So I'm really interested in those two quite different settings, what the impact has been in trying to maintain a collaboration with other partners in the healthcare field who are helping your patients.
So I'll speak specifically to, well, I'll speak about both, but I'll start with the nursing home. And I think that they've always had respect for the psychologists. But I think when the facility is in complete lockdown and the patients are anxious and feeling depressed and very withdrawn and getting isolated, I think there's been more of a respect for the clinicians in the facility because they found our services to be really important in keeping those patients stable for this long duration of time where they're without the family support that they're used to. So we've had to communicate more with all the members on the team, just making sure that we're all on the same page about this patient, what's happening, did you notice any symptoms, and us communicating regularly. And in addition to that, I'm communicating with the other 5 psychologists that are also in the building because on the days that I'm not there, they're filling in possibly for my patient that might be in distress or feeling overwhelmed on that day. And so we're all communicating about either the same patient or just trying to keep on the same page about what's going on overall with all the patients, just making sure that everyone is maintaining stability. That can be difficult because sometimes the patients are in and out of the facility. They're going to the hospital, they're coming back. To the hospital and coming back. And so each time they go out and come back, the need may be the same or the need may be different. And so it's revamping the plan each time. In addition to that, keeping in touch with the family as long as we have permission to do so, just making sure that the family is, informed, updated, and just providing that support. So a lot of the work that we did is not necessarily with the patient, it's with the family. And I'll be honest with you, very transparent. I feel like the staff benefited from having the psychologist on board as well, because there were moments of what I would call them just panic, a meltdown, if you will, about being short-staffed, feeling overworked, feeling sometimes uninformed, and we were sort of the in-between and passing information down about either what was going on with the patient or just helping them to feel more stable in a very uncertain, unpredictable environment. So that's the nursing home. I'm hoping I answered that question. In my private practice, we held regular meetings with our staff. So we have a staff of 8. But we found during the pandemic that things sort of plateaued a bit. And now that we're still in the pandemic, but towards June and July, the phones picked up in a way that we could not have imagined, because I think people were sort of coming out of it and sort of realizing, oh my goodness, I just went through that, or I lost a family member, or I lost many family members. And for us, just rising to the occasion to find staff. So we're actively looking for clinicians to join us, and not just clinicians just to join us, but to be able to meet the needs of the community and what they're coming in with. And they're coming in with anxiety. And I think that that's like the number one thing that we're dealing with. A lot of anxiety because of uncertainty, the unpredictability. Are we going to have a second wave? What do I do with my children? This has been very chaotic. I'm at home working and I have my kids. Do I send my children back to school? dealing with a lot of that. And then grief and loss, because they've lost family members, they've lost colleagues, close friends. I've lost a few people into the pandemic as well. So just moving our practice to remote, but also trying to increase the services that we do provide to meet the needs of the what we're dealing with. People who are versed in grief and grief counseling, and folks who can help with anxiety management and coping skills and dealing with depression and loss.
So Leah, can you talk a little bit more about how the teams worked when you provide something we often overlook, which is basic nutrition? Did they have a full understanding of your importance for their patients? And did you play a different role during COVID?
Yes, thank you, Elizabeth. I was hoping to actually speak more on interdisciplinary teamwork. So just to kind of not sidetrack for a minute, still on topic, I really got, I need to thank URI for my, my upbringing with multidisciplinary teamwork. From a young age and a young sophomore at the university, I was exposed to interdisciplinary work, and it just had such a great impact on my career. So all of the students listening, all the faculty listening, please, get involved, know more about the other disciplines, what other majors, get involved as best as you can, because it will just help you tremendously no matter what line of work you go into. In the hospital setting, it was huge. And Elizabeth, like you said, sometimes nutrition is overlooked, and that's, unfortunate. I think it's because it's such a basic fundamental of being. We all, just assume that, you eat and you're healthy and you're well. However, when you're working in different communities, as Fernandez was saying, you don't know the socioeconomic status. You don't know what somebody's health is like or what their upbringing was like. So now they come into the hospital and we don't know, are they malnourished? Do they have any deficiencies? What do we need to correct, along with, making sure that we're preserving their body mass, I was saying, and helping them on a road of recovery. So, in these more critically ill patients, the dietitian played a huge role in making sure that people are being adequately fed so that they can recover and live, fulfilled lives. We worked constantly with nursing, and I can't say, everybody knows by now with the COVID how much of rock stars nurses are, but they truly, are just so incredible and so incredible to work with as well. You really learn, how much they do for their patients, and it's just, I had a lot of respect, but I just have so much respect for nurses and all the healthcare team. So, we are constantly working with them, finding the best practices of providing great nutrition, but, in a way that's clustered, in a way that keeps the nurses safe as well. That was a very big thing. And with all of the new information and the different guidelines, every day we were learning about, okay, this supplement, this tube feeding is appropriate, or, maybe we should consider this one, and kind of talking with the team. And as James was saying, there's different manifestations. He spoke a little bit about the respiratory. I saw a lot of, renal diseases requiring dialysis, and even, GI manifestations, abdominal distress, ileus, what have you. And that really plays a huge role in how we feed them and their plan of care with nutrition. So again, just going back to the team, talking with the nurses, talking with the doctors, to figure out, what's the best plan of care. It's constantly changing. That's why, teamwork is so important. You need to have a good relationship with your team. You need to understand their roles. And if you can do that at a young age, I really, encourage you, get a head start. It's, important, whatever you'll do.
Thank you so much, Leah. So we're getting a bit late, but before we go to the Q&A, I would like to do a bit of a lightning round. You all have told some very compelling stories, and I would love to ask each of you if you could briefly say, what is the thing you would change or that you think we should learn from this pandemic? And I think I might go in alphabetical order again. So Dr. Fernandez.
Okay, so sure. So just first of all, I wanted to say that this pandemic experience, among other things, has been an education in public health, just to show how so important it is where you live kind of just influences what your options are and informs your health outcomes, right? So if you live next to a Burger King versus living next to some natural organic food place, where are you more likely to eat, right? At the same time, if you have only $10 in your pocket and you have 3 kids to feed, are you gonna get food for a day, or are you gonna get 10 double cheeseburgers, right, from someplace, and be able to feed your family for multiple days? So yes, where you live and the access you have to source resources informs your health, and that's what public health is about. The one thing I would change about the healthcare system, to keep it simple, is we all know the U.S. healthcare system is not perfect. Is probably, I would make it so that it's not, the sicker you are, the more money we make. I would probably just change that.
Dr. Gale.
Yes, that's a very heavy question for me. I would say that I live in a neighborhood that is pretty racially and ethnically diverse. And I feel that, it's from a personal place, but also professional place, that I feel that the needs um, of the economically disadvantaged were not met in the beginning of the pandemic. Working in healthcare, I witnessed people being turned away because of not enough testing, or being sent home to ride out the symptoms. In the news, I saw long lines of people waiting to be treated, and then waiting for hours and being turned away. And I feel like people of brown skin were dying at a disproportionately higher rate than people from other communities. And if I'm given the platform to speak on that a little bit more in detail, I probably could and would love to. But some communities struggled more than others. One, to get access to care, and 2, they were not heard when they said that they had symptoms. And I just feel I'm almost traumatized by watching the news, especially the neighborhood in which I live, in the surrounding neighborhood, just watching the trucks pull up and people posting things on Facebook, and me actually driving by and actually seeing the trailers outside of the facilities that I know are in economically disadvantaged areas, and how I'm not really sure what was going on inside the facility, but I don't know. I know for a fact that we were inundated, we were overwhelmed, and I think that created immensely to the anxiety and the sometimes anger about why family members were passing away in comparison to maybe somebody that they watched on the news who we know has a little bit more money. So if I were to change something about the healthcare system, I don't know if it's changeable, but it's something that I noticed, is that there were racial and ethnic disparities in healthcare during the pandemic. Certain communities were affected much more than others, unfortunately. Don't know the reason. I'm still researching and trying to find my own answers, but there were some heavy hit areas, really, really heavy hit areas, and still continue to be that way in terms of the rates that are rising in New York. So
Thank
that's
you.
my.
For our audience, in 2 weeks from tonight, that will be the very focus of our panel, is around disparities and how COVID has made them much more visible than perhaps they were before. So thank you for sharing that. Leah, could you share, if you were going to change something based on the experience you have had, what would that be?
So Dr. Gale, Dr. Fernandez, thank you so much for your insights on the community aspect. That is, so important for people to hear. And I hope, you continue to tell that story. A little bit different. I was in the inpatient clinical setting. Not necessarily things I would change, but I mean, just to say, always be an advocate for your patients. Sometimes when they're hospitalized, they can't stand up for themselves. Like James says, their family members don't know what's going on. Always advocate for them. Always, be a strong supporter of them, stand up for them. That will always be huge. And always, be a lifelong learner, in whatever field you go into, always want to learn and develop your skills as best you can. Learn about different people, different populations, different jobs, just, never stop learning. I would say one thing working in the healthcare system.
Great. James.
Yes. To Dr. Gale's point, the healthcare system does need to change, and that starts at the top. But that's a discussion for another day. So that being said, a lot of our discussion has been patient focused. I think that this COVID experience has certainly humbled me. I can't speak for everybody else, but I can say that we need to watch out for each other. Healthcare workers in general, whether they're working in a hospital setting or pharmacy or in a long-term care facility, these people that are doing these jobs, caring for sick people, they're also going through this pandemic as well. They're going to work, they're going home, they're isolated. This is all happening to everybody, and some people take this job home with them, and not everybody deals with it the same way, and it may not be in a healthy manner. So I think we need to listen to each other. We need to watch out for each other, and we need to talk, and especially listen. Listening goes a long way, and I've definitely feel I've become a better listener since this has started, because you can visualize something. You can look at a colleague and say, you know what, something doesn't quite look right, and you have a discussion, and next thing you know, you're having a full-on discussion about something that you really didn't anticipate, but it was really therapeutic for both of you that, this conversation did happen. Not that patient care isn't important, because it is. That's why we do what we do. But we got to remember, we got to look out for ourselves too. Personal health and personal perseverance is just as important, because if we're sick, we can't help the people that are sick.
Thank you. And Shannon, is there something from where you sit in public health at the State Health Department that you would change?
Yes, definitely. I think the biggest lesson that I've learned, and to Dr. Gale's point and Dr. Fernandez, is definitely that the health disparities and health inequities that we've seen in our disadvantaged communities have been affecting vulnerable populations much, much more than more of the non-disadvantaged communities, especially in Rhode Island. We've seen the high density communities, Hispanic, Latino, just getting disproportionately affected. And something that I had always learned throughout my career at URI was about health disparities and about that being really the main driver and focus of public health, and mitigating those disparities through education and outreach. And I worked a lot with different populations throughout my career. And I think when I was at URI pre-pandemic, it was a lot more of chronic disease disparities that we had seen, and working with individuals with obesity, with diabetes, with all of those diseases. And now COVID's kind of an extra layer onto that. It's another burden of disease that is really affecting our communities. And I think moving forward, it's given everyone in public health and in clinical healthcare a chance to be an advocate and raise their voices for those individuals and communities that they're working with.
Thank you. So thank you all. And I now want to turn to a few questions that have come in, and we don't have time for everyone to answer them. So I'm going to kind of let someone jump in first, and perhaps if there's one other person. So the first one is, and this goes to something James mentioned, how do you manage your own self-care during such a stressful time?
Well, my life has changed. I can say that. My wife has pulmonary issues, So I have to be very careful in what I do daily so I don't affect my wife. I will come home. I told my neighbor from the very beginning that if he sees me wandering out in the backyard naked, I'm not doing anything illegal. I need to get undressed in the backyard before I enter the house. So none of this, I could trach it through my house so my wife doesn't get ill. That's an adjustment, you know. You have to be mindful of what you do, what you touch, what needs to be cleaned, shoes that you wear. None of that I wear at work. I keep what I can at work, but what does come home with me doesn't enter the house. It's an inconvenience, but it's a necessity. Until we can figure out how we can, stop the spread of this disease, we need to be conscious of our daily activities. And that's one way that I do.
Anyone else want to?
Yeah, I think speaking as a psychologist, I'm a big proponent of self-care, but again, transparency is key. I've found it very difficult to take care of myself in the midst of trying to take care of my children who are at home, trying to take care of my patients, trying to make sure that the practice is up and running, trying to make sure that I'm going to the nursing home and trying to meet the needs of all the patients there. It was a very, very difficult time to practice self-care. And I found that talking with my husband, who's also a clinician, and my sister, who's also a therapist, that proved to be very helpful in just sort of ventilating a lot of the emotions that I was going through and just feeling overwhelmed so that I could be present for all the places that I needed to be and all the people in which I interact with. But I think that healthcare workers, self-care, it can take many different forms. It doesn't have to be this one thing, but therapy has come to the forefront, and I think a lot more healthcare workers are seeking therapy. So if you're out there and you hear me and you're a healthcare worker and you have no place to really talk about your feelings and what you went through in the height of the pandemic, I think that therapy is a wonderful outlet. We've had many healthcare workers come in to see us over the last couple of weeks, just talking about what they've experienced and the trauma that they've dealt with. And I think it's been a good outlet for them. And it's been a good outlet for me talking with my peers and family members who are my family members, just getting it off my chest, getting it out there about how I'm feeling and how I'm doing has really been helpful. So I would recommend that to other healthcare providers.
Thank you. So we have another question, and that is, what would be your message to the public as the pandemic wears on? We've mostly been talking about the past 6 months, so it's an interesting question. Does anyone want to take that one on?
I mean, sure, I'll say something, Elizabeth. My message is pretty short, simple. It's wear your mask. We still have to say this in September, but definitely say this in September actually, because you got the flu coming in. I'm giving out flu shots already. By the way, it takes like about 2 weeks for the flu shot to actually start protecting you. So the earlier you get it, the better. Doesn't protect you immediately. So wearing your mask is key. People come in, I say, you gotta wear your mask. They don't have a mask on, I give them a mask. And they gotta put it on right there, right in front of me. And that you just go with that value and you bring it with you everywhere you go. And you just hope it disseminates within the community. So my message is short and simple: wear your mask.
Thank you. Anyone else have a particular message as we're kind of looking forward?
I think it's be flexible. I think we were not used to, I don't like change. Many people don't like change. And this was a big change. I think as we look forward, just sort of be able to flex. If that means getting a call from your child's school saying, we need to close this classroom down, you have to be open and receptive to that, because I found that a lot of parents were very angry about that. Why does my child have to be out of school? Can't you find some other provisions for them? No, it means that the school is shutting down because there is a health risk. So you need to be as flexible as you possibly can be around that. I understand that it can cause an inconvenience, but we have a health crisis going on. Oh, why can't I come into the office to see you? I understand that face-to-face is optimal, but right now we're in a health crisis. So let's see how well Zoom can work for right now until we all feel safe to go back into the office, and then we can reconvene in the office. So I think that people moving forward, again, wearing your mask, yes, but also being flexible, because we don't know what the future holds with this pandemic. As we've seen, it's taken us on highs and lows, and there's lots of information that we don't know and things that we do know, but just I think for a lot of people it was inflexibility, and that's where a lot of the non-mask wearing came in, because we just didn't want to change from our old way of life. It's time to try our best to adapt to the new way of living, as uncomfortable as it may be.
So thank you all so much for what you have shared about your professional responsibilities and roles over the past 6 months, but also for many of you, your very personal experiences over the past 6 months. And that gives us an even more important window into what it means to be a professional at this time. And I really want to thank you for sharing that experience. I want to thank our audience for joining us. And I hope that maybe some of our panelists, but also our audience, will join us next week when we talk about what has happened with older adults, and the following week when we talk about something that came up quite a bit, which is health disparities. So thank you all. Once again, really appreciate the very important things you had to share with us this evening. And good night.